Good day. Today we're going to continue our voyage through the nervous system and begin with a study of the spinal cord and then the spinal nerves that come off the spinal cord. If you remember now, the spinal cord, because of its position, is going to carry all the information that has to come out of the brain and brought to the body. Except for 12 cranial nerves, which we're going to study in another lecture, all the contact, both motor and sensory, are going to come out of that spinal cord. We always think of the brain as the very top, so that even when we have, for example, a sensory neuron on the top of our scalp, it still actually has to go down through the neck and back into the spinal cord and then up again. So the brain is the top of the whole system. The spinal cord exits that big hole in the bottom of the skull called the foramen magnum, and that's the definition of the beginning of the cord. Everything else is considered the brain stem until we have that exit into the body. Now, when you think about this, the spinal cord, it's still part of the central nervous system, and it's going to carry so many fibers that it's kind of hard to conceive that it's about the size of my thumb. And yet every fiber going up and down is going to be carried inside that cord. Remember again that we have ascending or afferent fibers that bring sensory impulses up to the brain. We have descending or efferent motor fibers that carry the impulses out to the rest of the body. There are some fibers that actually skip the brain entirely, and I'm going to talk to you about that in a minute. These are spinal reflex arcs, where the impulse will come up from the body, signal something happening, go right through the cord and back out to the motor neuron and skip the brain almost entirely. And this is a survival mechanism. The spinal reflex is something that allows very quick action to take place. Now, the brain is going to modulate these kind of reflexes and act upon them to either speed them up or slow them down. But still, it's the secondary player in the spinal arc, which I'll go into in some detail. Let's look at the anatomy of the spinal cord with our first slide. First of all, the spine itself runs from the base of the skull, which it carries. Actually, the first process or spinal body is called the atlas because it holds the head up. And then the second one is the axis because the head rotates upon that. And it goes all the way down the body. This is a view of the back to the tailbone. It's divided into 4 segments. The very top are called the cervical, which means neck. And you see here the numbers C1, 2, 3, 4, 5, 6, 7, 8. There are actually 7 vertebrae here, but 1 spinal nerve, which is what this refers to, comes out at the top, above the first one, and below the last one. So we have 8 spinal nerves exiting the cord. Then in the chest, which is called the thoracic vertebrae, we have 12 of these. And these are labeled T1 through T12. And the thoracic ones come out all the way down to the level of the upper back. And then next we have the lumbar area, which is the curved portion of your back, and the lower portion, and we have L1 through 5. 5 nerves come out there. And finally, we have the sacrum, which has 5 more nerves coming out, and the difference being that the sacrum is fused. While we have separate spinal bodies for every one of the levels here, all the sacrum vertebrae have been fused in evolution as one bone. Now, the other thing to note up here is that if we were to look at this from the side, we have curves. We have actually looking from the back, a concavity in the neck. We have a convexity in the back, which is called a kyphosis. A concavity is called a lordosis. In the lumbar section, we have another lordosis and another kyphosis in the sacrum. So if you looked at somebody from the side, you would see their neck, if I'm facing this way, the neck curves this way, and then the chest curves out, the back curves this way, and the sacrum curves out again. And that alternation of lordosis, kyphosis, makes the vertebral column like a spring. And it gives a little bit of movement so that there's not quite so much impact with every step or running or jumping. It's our shock absorber. There can be variations in those. Excessive kyphosis is a humpback, sort of like the humpback of Notre Dame, or excessive lordosis, a swayback, can lead to actually spinal abnormalities, pain, and problems in the spine. Also, the fact that we were never really meant initially to walk upright means there's a lot more pressure on this column than we have evolved to tolerate. And that's why we have so many back problems these days in modern society. Now, the coverings of the spinal column are very much like the brain. They extend from the brain, they're continuous with the brain, so there really is no change. We have the meninges, and again, the outer layer of the meninges is the dura mater, covering the spine here. You have an arachnoid, and then you have the pia mater, which, just as in the brain, is firmly attached to the cord itself. This slide shows the exits. Now, we're looking here from the front to the back, and this side is showing the exits of the spinal nerves, both front and back, and then joining together as they go out to the body. The other thing it shows here artificially by dissection is two very tiny spaces, a subarachnoid space and a subdural space. This is an interesting area. These spaces are filled with cerebrospinal fluid, exactly the same and in continuity with the brain. So there's the continuous relationship of the fluid around and in the brain with the fluid around and in the spine. And if you remember the ventricles that are inside the brain, look at the tiny little hole right here. There's a little canal filled with spinal fluid that is continuous with those in the brain. This gives us a very good access to the physiology of the brain, because we can put a needle in here and extract some fluid, which is different than the blood, and we can see what's going on in the internal milieu of the spinal cord and the brain itself. For example, if you had an infection like meningitis, which can be an infectious disease, this is inflammation of the meninges, often caused by a bacterium, you could put a needle in and you might find lots and lots of white cells, anti-infection cells that don't belong there. You might even find bacteria and be able to grow those bacteria to make a diagnosis. There's viral meningitis, which you probably couldn't grow, but you could still see the kind of antibody producing cells that are in that fluid that don't belong there. So we can make diagnoses based on cells and proteins or blood in that area to tell us what's going on. That's taking things out of the spinal column. The other thing we can do is we can put things in there if we need to. We can go in, and in the epidural space or the subarachnoid space, we can take a needle and put in an anesthetic agent. And we can then paralyze or anesthetize any of these nerves that are coming out below the level of our anesthesia. So if we were to anesthetize the cord at this level, everything below it might be paralyzed. And we can use, for example, a heavier than normal solution and keep the patient slightly head up so it stays low. Or we can tip the patient down to move the anesthetic up. You know this is spinal and epidural anesthesia. Now, these anesthesias are very effective. One of the problems with them is, especially spinal anesthesia, is that once it's in, it's in. And it's in for so many hours, usually 4 or more hours, and you can't reverse it. So if we have an operation that's going to take a half hour or an hour, we're going to give this patient 4 hours of anesthesia, which is not necessary and has some downside to it as well. You also can have the problem of what they call an ascending anesthesia, accidentally getting the anesthetic agent too high. And if it gets high enough, it can start preventing the patient's muscles of respiration from working. And if it got really high to, let's say, the neck and knocked off the muscles to the diaphragm, the patient might stop breathing altogether. This is a rare occurrence, but it does happen. The other problem is also you've made a hole when you put your needle in here, and you may have removed some fluid for diagnosis. Now, the brain, like any other cavity, is used to a certain pressure around it. If you remove too much fluid, things are going to sag. The brain's going to sag, the cord, and the vessels and nerves are going to be put on stretch. And this is one of the mechanisms for the post-spinal headache. Patients who've had a spinal tap or have had anesthesia may either have had too much fluid removed, or they may have a leak through that hole for a while. And although that'll close, they can get a terrible headache after this procedure, and it's why it's not the preferred procedure today in anesthesia. You can prevent this by using very small needles, so the leak is minimized. You can add fluid back in, measured by the amount you took out, so that can help. But still, we have better methods of anesthesia today. And other than the epidural, which happens to anesthetize less of the whole cord, just the nerves coming out, we don't use much spinal anesthesia anymore today. Now, if we look at another aspect of the cord, there's an embryologic significance that's very interesting. I mentioned to you that the cord and the brain were very well developed at birth, except for the insulation. We had an almost fully developed organ that doesn't grow very much. And in fact, the spinal column grows much faster than the cord as we get to maturity. So if you look at what's happening here, you see the cord coming all the way down to about L1, T12, where something called the conus medullaris, which merely means the center of the cord narrows, and all we're left with below this are the actual nerves themselves, which are continuing to go down and go out their exits. You see here, for example, almost all the nerves come off the cord above the level they exit. Here's a nerve coming off the cord at around T4 and exiting at T5. That becomes more exaggerated as you go down until you get to the end of the cord, where these nerves have to travel a long, long way, and they form inside the canal something called the cauda equinus, or the horse's tail, because these are all the filamentous nerves that are going the rest of the way. And we make use of this, because reality is that we don't want to put a needle in up here. I would not like to put a needle in and take the chance that my needle is going to go through the dura and stab the cord itself. I might cause bleeding. The sharp edge of my needle may transect a few tracts of ascending or descending nerves, and that would be a bad thing. So instead, what we do is we always go below L1 or 2 in trying to get our needle in there. We pick a level at which, for example, if we wanted to get some of the L2 and L1 nerve fibers, we'd pick a level where we knew they were still in the cauda equina. And as you put your needle in, you have now a bunch of fibers floating in cerebrospinal fluid, and even if you were to touch one, it would probably float out of the way, and your needle would go past it. If you touch a sensory fiber, the patient might say, my toes are tingling, or you might nudge a motor fiber and the knee may involuntarily jerk. But aside from that, it's a much safer place to do this, and so we capitalize on this kind of anatomy when we go in and put needles and other invasive procedures into the cord. Now, the structure of the cord is very complex, and it's quite different from the rest of the nervous system. If you remember, the nerve bodies, the cell part of the neuron, was on the outside of the brain, and we called that the gray matter. And then the axons and dendrites, the little projections of the cells, were on the inside, and that was the white matter. Some of them had myelin insulation and some did not. If you look at the next slide, in the cord it has completely reversed. This is a section across the cord, and the orientation is that it's a horizontal section, so we've cut the patient right through the middle, plane, the way we've shown you before. You should be getting used to these terms now. And we're looking down on top of that cut section. This disc represents the whole cord. Here's the back of the person, here's the abdominal side, the anterior side, and here's this butterfly-shaped part of the cord, which has been shown raised for clarity. This is the gray matter. It's on the inside of the cord. The white matter and the tracts are now on the outside. Now, in the spine itself, this is a very basic representation. What we have is the afferent fibers, the incoming fibers of sensation, whether they're from the viscera or from the body itself, the somatic area, come in a combined nerve. This is the spinal nerve, and it enters the cord on the dorsal or posterior or back side. We talk about dorsal and ventral. Ventral meaning the stomach. There's a swelling here because the bodies of this neuron, we have the dendrite here and we have the axon here. This area is swollen because they also contain the cell body as well. It takes up more space. And we call this swelling a ganglion. Now, this one is showing it going through the cord, through the this horn here. This is a posterior gray horn, and synapsing with a motor neuron. The word synapse is a connection between one neuron and the next, and I'm going to tell you how that occurs. Then you have the body of the motor neuron in this part of the horn, which is the anterior gray horn. And this has a little swelling too. You see, this is a little bigger than this horn because it contains cell bodies. And this goes out to the motor effector organ, whether that's to constrict a gland and make it squirt, and whether it's to move a muscle. All the motor neurons go out this side. It's of interest that there are diseases that are very specific for this anatomy. For example, polio happens to like to live in the motor neurons of the anterior horn right here. And when patients got polio, the viruses attacked these cells specifically, not any of the other cells that we knew about, and they would destroy the cells, and therefore the person became paralyzed. Whatever organ that those lower motor neurons were innervating were dead. And they got a flaccid paralysis. The muscles would atrophy. Now, many of them happened from the waist down, so the patients had polio in the lower half of their body. They were paralyzed on one or both sides, often both sides. And it could also occur up in the neck. If this occurred up in the neck near the bulb, the lower portion, it was called bulbar polio, and it could affect the muscles of respiration. These are the patients that had to be in the iron lung because they required assisted ventilation, and this was very fatal if they did not recover. This also tended to be a wealthy person's disease, just out of interest, because infants, very small infants, had a good tolerance for the virus. They would get sick, but they would recover, whereas older children and adults had very poor tolerance and would get paralyzed. Now, this virus is passed by what's called the oral fecal route. It is transferred from feces contamination in the stool to hands to the mouth, and that's the way the infection was perpetuated. In the wealthier upper level, in the socioeconomic ladder families, the babies were kept meticulously clean in their infancy, and they had no exposure to the polio virus. In the lower socioeconomic levels, it tended to be less so, bigger families, poorer living conditions, and the virus spread through the infants very early, and they developed a resistance to the virus. So it was an interesting reversal of what usually happens in our healthcare system. It favored the lower level patients. That was polio, and this is basically the cord. Now, we're also going to see a number of tracts in this next slide. This shows the same thing from a little further along. Now, here was our motor entrance and exit, but the ascending and descending fibers, the dendrites and axons, travel out in what are called tracts. And these tracts have long names. They're just named after their shape. This is gracilis, fasciculus, gracilis, which just means slim. This means wedge-shaped. And then you have a spinocerebellar tract out here, which means it just goes from the spine to the cerebellum. There's an anterior one and a posterior one. You have a spinothalamic tract, which you can immediately figure out goes to the thalamus, and so forth. We know exactly where these tracts were. These are the ascending tracts, and on this side, they're showing the descending tracts. And of course, they're on both sides. They're mirror images of each other, but this is shown separated for clarity. There are cases in which patients, for example, might have excruciating pain from some disease that's not curable. And their life is not terminal, but their life is miserable because they can't function with the pain. Neurosurgeons have gone in and known exactly where those tracts are and very carefully severed them just above the level where they entered the cord and blocked pain perception. Now, they also block touch and proprioception, and that limb, for example, that may have been blocked is now completely numb. But it can function because the motor tracts have not been cut. Remember, the motor tracts may be somewhere else. And so this was called tractotomy and used to help patients who had intractable problems but not necessarily fatal disease. There's another area of this anatomy which comes into very practical medicine, and that's the area of arthritis and herniated discs. Surely everybody has heard about those. In this picture, we now have a section through the cord again, much more realistic drawing of what it looks like. This is anterior, this is the abdomen, this is the back. First of all, the parts of the vertebral column, this is called the spinous process, and when you run your finger down the center of someone's back, those are the little bumps you feel. And then you have these two processes here protecting the back. Look how much protection you get. These are paraspinous muscles, plus all the rest of the muscles in the back. You get tremendous protection of this very critical organ. And then in the front, this is the body of the spine. And then here are the ascending and descending vascular vessels. And then you get into the dura, the arachnoid, the pia, and the cord itself. Look at the spinal nerves, anterior, posterior roots joining together and exiting in this nerve as a mixed nerve. Two things go on here. First of all, where these spinous processes join, you have an upper spinous body also touching here and bridging across. If you get arthritis in this area, inflammation of the bone in the joint, then you can get narrowing of the exit and you can start getting impingement upon these spinal nerves. And that will cause either pain or numbness or even loss of motor function in the area that is distributed by that nerve. Okay, those are arthritic changes. We call this degenerative or osteoarthritis. And the other thing that's probably even more common is that between two vertebrae, top and bottom, is something not shown here, and it's called the intervertebral disc. Now, the disc is a sponge-like pad that allows cushioning between the two vertebrae. This tends to degenerate over time with aging and trauma, and most of us have had some symptoms of this, one of which is that we get shorter as we age. There's more than 30 of these discs, and if each of them just shrinks about 1 millimeter in its size, which is very little, you're talking about a loss of more than an inch, inch and a half in height, and they can shrink a lot more than that. Second thing that happens is they can start losing their integrity. They have a central cushion that's almost liquid. And what can happen on exertion is the posterior or back edge of that disc can rupture. Not only the disc, but just what contains the disc. And that disc, because of the pressures from the front, can be pushed out to the back, and you'll immediately see what happens. It can impinge upon the cord or upon the nerves themselves. And this can take great trauma to happen, or it can take very little. I've seen a patient who bent over to pick up a tissue off the floor, and in flexing the back, fired the disc out the back and was paralyzed instantly. Now, he was fortunately at a hospital, and when he did this, was taken right to surgery and had that disc decompressed and was able to regain his walk. This is not an uncommon problem. It happens at all varying levels of magnitude, from just annoying pain, disabling pain, and sometimes even paralysis. And it's an area that we also have a problem with because surgical intervention can sometimes make the patient worse rather than better. And yet some patients are absolute miracle cures and walk away from this with no problem at all. I want to talk to you also about another disease which none of us would know about except for the famous Lou Gehrig. It's a rare disease. It's called amyotrophic lateral sclerosis, or ALS. Everybody knows it as Lou Gehrig's disease. And it's, I bring it up in the same context as another very common disease called multiple sclerosis. These are diseases. Lou Gehrig's disease basically is a degeneration of the motor neurons in the cord, and what happens is the patient becomes progressively paralyzed. They get weakness at first, very subtle symptoms, difficulty swallowing. It's very, very vague, and then progressive spread through the nervous system until these patients finally are paralyzed and die. It's a disease without a cure. We can keep them alive by breathing for them, but it's a great problem for the patient. Fortunately, not a very common disease. Multiple sclerosis is another disease, though, that's much more common. It unfortunately affects young people, and it's very sporadic. The disease in one, it's called multiple sclerosis, but the multiple happens to apply to the fact that it happens in different areas of the nervous system. The sclerosis, you've heard me use that term before, sclerosis means hardening. What happens in this disease is that different areas of the nervous system get a very patchy, random hardening of nervous tissue and destroying the nervous tissue function. Now, we have something in medicine called the paucity of diagnosis theorem. What this means is, in most cases, you would like to blame all the symptoms that a patient may have on one disease, because most of the time we only have one disease at a time. So a person who might have a cough and a headache and a runny nose, you don't want to conjure up a brain tumor and an allergy and something else in their lung. You would say this patient has the flu. One disease should explain all the symptoms. Occasionally you get fooled and the patient has more than one disease, but by and large you look, especially in neurology, for one disease to explain it. In this disease, what happens is we get fooled because the patient may have a whole bunch of symptoms that are referable to different areas of the nervous system, the brain and the cord, and different parts of the brain and the cord. And that's what happens in multiple sclerosis. These patches are in different areas. There were lots of theories. It was once thought to be a viral disease. I think that the best theory currently is that it's an autoimmune disease, in that the patient becomes allergic to their own nervous system and attacks their own nervous system in a spotty manner. Today, these patients, actually many of them, do very well. It is not a rapidly fatal disease. There's good treatment, although there is actually no cure. Let me talk to you next about the reflex arc. I alluded to it earlier in the slide, and if we look at this slide right here again, we talked about impulses that come up from the periphery of the body, go across in synapse inside the horn here of the anterior gray matter, and then go back out to a motor effector organ. Keep that picture in mind. When we evolved, we needed some mechanisms to save time in the emergency situation. We're back to that emergency situation again. So if I'm standing in the kitchen and I put my hand down on the red hot plate of my stove, what happens is this. My pain sensors immediately sense heat, pain, and transmit this up through this first motor neuron and down to this synapse. It will then go immediately, without going to my brain, back out and make me pull my hand away. I have pulled my hand away before I even recognize that I had the pain. I actually feel the pain probably when my hand's up here. Now, the brain has not been excluded from this. There's another neuron right about here that goes upward to the brain to say, this guy's burning his hand. It happened so fast that I have responded with no conscious knowledge. What happens is that my hand gets burnt, the neuron signals it, my bicep contracts, my tricep relaxes so that I can pull my hand away, and then I may smell the flesh burning and start screaming. The ouch comes long after my hand has left that plate. Now, this is a survival mechanism. It's the same way when somebody jumps out of the dark and yells, boo, you've already reacted before you know who it was, what the danger is. You've jumped, your heart starts to race, you're out of the way, and then you realize it's a friend playing a joke, or it's a lion that's going to try to eat you, and you have at least started the reaction. There are other systems that are very clearly related to this. For example, I mentioned pain on the cornea, but also the eye, when the pupil, for example, opens and closes. There's a reflex arc there. If you shine light into one pupil and it's too bright, that pupil reflexly closes down. There's no conscious component there. And the other pupil will close down too. So these arcs go across the spine sometime as well. They react to all the changes in the environment. They are mostly what we call monosynaptic reflexes, meaning there's one synapse here and it goes across to the other. There's sometimes an intervening neuron in the middle of this, and that is called an association neuron, but that's not really of significance in the physiology that we're talking about. Let me digress for 1 second and talk about the synapse, since we keep coming back to it. We have to get the electricity that's coming down here to get across this gap. This is done by a neurotransmitter. I will come back to it more, but basically it's a chemical. It's no longer that electrical impulse. It jumps the gap by physically releasing chemicals wrapped up in little packages that go across the gap and stimulate the other side to start its electric potential. And it's immediately broken down by an enzyme which stops the chemical from working for more than that millisecond for one impulse. Now, I'll go back and talk about what those neurotransmitters are, but that's what I'm talking about when I talk about a synapse. Let's look at the reflex arc a little more because it is such an interesting area. It's so primitive, and one that you may want to see in some detail. We've all had the experience of sitting in the doctor's office and having him hit us in the knee with a hammer. What he's testing is the reflex arc, the integrity of that reflex arc, and more than that. For example, in the knee, there's this patellar tendon, which attaches your kneecap, the patella, to the lower leg, and it is attached by a tendon and then by the muscles of the upper thigh. So when you contract this muscle, it pulls on the leg and you have a knee jerk. Your leg swings forward. When the doctor taps here, he is going to stimulate a stretch receptor, because that tap pushing in on this tendon is going to pull on the whole tendon, and there is a receptor, which is microscopic, it's not this big, inside the muscle, all throughout the muscles. That stretch receptor is going to tell the body that I've had a sudden change of length, and muscles don't like sudden changes of length. They like gradual change of length. What the muscle will do if it gets a sudden change of length is try to contract against it to prevent it from happening too fast. So the reflex arc is that this signal goes out. Here it is in the posterior or the dorsal root. There's that cell body in the ganglion. Some is going to the brain, and some is going to go down here and out the lower motor neuron to the quadriceps muscle, which is going to contract and kick your knee out. At the same time, there's going to be an inhibitory associative neuron going to another motor neuron to relax the hamstrings so that you can kick out. It's a little more complex than the first example I showed you. And then finally, there'll be some information going up to the brain to let it know what happened. How is this clinically important? First of all, if a patient has had paralysis of the cord at that level, there won't be any reflex arc. Polio, for example, there's no reflex arc. If the patient has had some interruption to the upper brain, higher up, the brain's not going to get any information. And what happens is that reflex is wildly out of control. There's no more inhibition to the magnitude of the kick. It's called hyperreflexia. So the doctor will tap you on the knee and the leg will swing wildly out rather than just a little, what you most of the time see is just a little boom, like that. And there are reflexes like this all up and down the body. If you've had a thorough neurologic exam, you'll see sometimes you have an ankle jerk on the Achilles tendon. They'll tap your knee. They'll tap your elbow here, your biceps tendon. There are wrist reflexes and so forth. And we can test those reflexes all up and down the body. The ability to detect neurologic disease is very important because despite the advent of the MRI and CAT scans and really space-age technology, which allows us to pinpoint lesions and problems within millimeters with great, great accuracy, I have to give a nod back to the neurologist who sits in the darkened room with you with a needle, a hammer, and a tuning fork, and just his body. A good neurologic examination, 95% of the time, can pinpoint a lesion within millimeters as well. In many, many cases, the doctor can get in there, look at your eyes, do extraocular motions, take a careful history, and do a complete physical and neurological examination, and can then basically develop as much or as little information as is there from the physical findings. And often, all those other tests are merely confirmatory tests. They don't add that much to the diagnosis, and that's happened for a long time, and unfortunately it's becoming a lost art. We now send the patient right through the MRI scanner and come up with a diagnosis. I guess that's good and bad. Let me let you look now at some of the microstructure of these nerves. When the nerves, here are the nerves coming out and joining. This is the anterior, so we know this is the motor neuron, coming out in many, many tiny fibers that look just about like this. You took a handheld lens and got really close. This is what you would see coming out of the cord. Here's the posterior root with its ganglion, its swelling. And here's the spinal nerve, and it has its covering. And inside, it keeps getting broken down into smaller and smaller and smaller units. They come out and form what is called a mixed nerve. I want you to remember that because we're going to talk about that a lot soon. And here is the vessels that feed the nerve. They travel with them, and they are protected inside because they're very important. This protection has two sides to it. You can be protected a little too much in the nervous system because of compression. Anyway, it breaks down into smaller bundles. At this point, the lining is called the epineurium, and it comes into fascicles, and those fascicles have a perineurium inside, wrapping each individual group of fibers, and you get what's called an endoneurium, and that surrounds the axon. Now, this is pretty microscopic, but remember, there are times when we actually get the opportunity to put these together. If a patient has had a severed nerve, and that nerve, I'm talking about something the thickness of a spinal nerve, and maybe as small as this, but most of the time, let's say something as big as a spinal nerve, by accident has been cut. There's one I'll tell you about later that happens in the face sometimes, that is the nerve that goes to the muscles of facial expression. We have a limited ability to regenerate nerves, but we have some, not the neurons, but the axons. And what you can do is you can take the cut ends cleaned up and of the epineurium here, not actually touching the nerves at all, and bring the good working end together with the old nerve, now the distal or far out nerve that's been cut, and sew them together. This has to be done under a microscope. It's done with very fine sutures, probably the diameter of a cobweb, and under a microscope with very steady hands, and individual sutures are placed here, 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 and tied individually all around this nerve. And then the nerve is usually splinted with tissue around it so it can't pull apart because these stitches are not very strong. And what happens is all the nervous tissue at the distal end, the far end, dies because it's been cut off from its blood supply and its nervous stimulation. Nerves that don't get stimulated atrophy. At this end, however, those axons have some ability to grow down and regenerate. And if you line them up properly, then they will find their way into that perineurium, or epineurium rather, and grow all the way out to the effector organ, if we're very lucky. Doesn't always happen that way, but it does sometimes. And what happens is these nerves can grow at a little less than 1 millimeter a day. So you can tell the patient when they might expect to find function. You measure the distance from the slice in the nerve to, let's say, the fingertip in millimeters, and it may be 160 days, if we're lucky, before you'll start feeling that first tingling or that first return of sensation. Okay? It's really hard to say why this does and doesn't work when it does, but we get some variable level of results that has to do with, number one, the nature of the injury, the trauma, the distance, the blood supply, and certainly the skill of the operator who's doing it. I've given you the impression that most of these nerves come out and, like the vessels, get smaller and smaller and smaller until they get to the end organ. Now, you remember in the vessels, sometimes we had an anastomosis. We had two similar-sized large vessels coming together, joining to form another collateral branch. This happens with the nerves too, and these are called a plexus or plexuses. If we look at the first plexus here, in the neck, I'm going to show you the main ones as they come out of the body, because they're very important. The first is called the cervical plexus, and look what happened. Here it is in the neck, represented coming off the cervical vertebrae. Here's C1, 2, 3, 4, and 5 shown, and they are giving roots and joining in loops. And then, for example, here's C3 joining some branches of C1 and then sending off their nerves. And it's joining here, and this one is joining here with these guys. So lots of these are coming together to form a plexus. This one is the cervical plexus, and it happens to innervate parts of the head and the neck in the body. This can be injured, and you get corresponding defects in the bodies. For example, you might get a cervical plexus injury with a neck injury, and this might affect whatever end organ, motor end organ, the patient has had injured. And I'll go into those as we get to each end organ. The next really important one is the brachial plexus. Look where it comes out. It comes out in about the middle of the neck, and it joins in very, very big roots from about C4 all the way down to a few fibers from T1 and 2, the thoracic ones. And they join to form 3 major trunks. This is an area that goes to the armpit and the radial side, the thumb side of your hand. There's one that goes to the median side, and then this one is called the ulnar side, or the pinky side of your hand. This is called the brachial plexus. It's in the way of a lot of things. Right here, broken collarbone, neck injuries. For example, it passes through the armpit. It's a big, big nerve, about the size, some of them the size of a pen. When a baby is born, the head is grasped, and in a difficult delivery, the head may be manipulated to pull that baby out. If there's a shoulder problem, getting the neck out, that can put a stretch on the brachial plexus, and the baby may be born with a temporarily or even permanently paralyzed or weak arm if we injure that. Have to be very careful in delivering babies that way. If you take a dislocated shoulder and reduce it or put it back wrong, it's right next to the brachial plexus, and the head of the humerus can ram into that and make for a bad repair. So there's lots of injuries that can happen at that point. Also, putting needles up into various structures here or dissecting in this area, one has to be very careful with the brachial plexus, especially, for example, in doing lymph node surgery in women with breast cancer. We have to be very careful not to injure the brachial plexus. Should know how to do that as surgeons, but we still have to take great care. Here's another one. This plexus is the lumbar plexus, obviously coming out of the lumbar area, and it goes to the inguinal canal in the groin, and it goes down to the femoral canal in the leg, so it innervates the groin and the upper leg, and again, injuries here can have consequences that are reflected in those organ systems. And finally, there's a sacral plexus, which goes down to the genitalia, to the pelvic organs, and can have ramifications in pelvic dissections. There are all kinds of things we can do to the spinal cord. We can have the spinal cord shift one vertebral body off the other. This is called spondylolisthesis. And when it does that, we also have the opening for the cord, and we're going to narrow that opening. Those two rings where the cord goes through are going to narrow, and we have something called spinal stenosis, very common. And what happens there is the cauda equina, those nerves are going to be compressed. When the patient is in an open position, which in this case is bending the body forward, it may decompress a little bit. This patient may have trouble standing up straight when he pushes this back into a backward position and emphasizes the narrowing. And that's the end of our tour through the spinal canal and the spinal nerves.